Welcome to our educational video. This information is created specifically for Abbott Northwestern H8000 nursing staff. The topic that we're going to cover is invasive EEG monitoring. As people know, invasive EEG is electrodes being placed under the skull, right on the surface of the brain, or actually into the brain. And there's two main types. There is the grids, which people are more familiar with because we've been doing that longer. And then there's the newer strategy, which is SEEG. And we'll cover both of these this lecture. Before you're going to be putting electrodes into somebody's brain, of course, you have to have a really good hypothesis as to where the seizures are coming from and a really clear plan. For that reason, what you want to do is you want to do a very thorough evaluation, the pre-surgical evaluation, thorough history, neuro exam. The patients are almost always have undergone scalp EEG here at Abbott. We do MRI, MSI, full evaluation. We get together as a group, we discuss what the plan will be, and we come up with our best strategy. Sometimes patients don't need invasive EEG. We know where the seizures are coming from. The surgeon can remove the brain tissue to get rid of the seizures. However, there are a selected number of patients who we need more information, and that's who goes for invasive EEG. Let's start by talking a little bit about grids. The way grids and strips work is they are placed on the surface. So surface. So this is the brain, right on the surface of the brain, and you have to have the concept, or at least the hypothesis, that the seizures are coming from the surface of the brain, and then grids will be very effective. If another goal of grids is to do cortical mapping, because you can stimulate the electrodes and figure out where eloquent cortex is. Things like where language function is, where motor function is, where sensory function is. These are all critical things to know for the surgical planning. Because if you're going to remove brain tissue, you don't want to remove areas of the brain that would cause a neurologic deficit. An example, next slide shows an example of an MRI with a patient with a left temporal lobe dysplastic lesion. Left temporal lobe often has language in it, so you can hypothesize, okay, seizures are coming from the area of that dysplasia, and if you remove that, you'll hopefully get rid of the seizures, but you may want to map out whether there's any language close to that. That way you can remove the seizure focus, but also not give the patient a deficit. Moving on now to SEEG, or stereo EEG. This has a different goals. So like I say, grids tend to be for the surface of the brain. SEEG tends to be more for the depth. And as you can see, these electrodes, they go deep. They go deep into the brain, and they can get us to areas that we really haven't been before. And because of that, if a patient has a seizure focus that is deep, SEEG is the appropriate way to go after it. Usually a patient will have, say, 10 to 15 of these small electrodes. So they're relatively small. They're placed through a small hole in the skull, and they go deep, and they can get into these areas. As noted on the next slide, you can see there are structures that SEEG can get us to that a grid just can't. Things like the insula, cingulate cortex, deep into the SMA or pre-SMA. These are really critical areas to explore, and SEEG allows us to do that. The invasive EEG tends to be relatively safe, but certainly can have complications. And nursing, of course, is on the front line if a patient has a complication with invasive EEG. Things to look for, of course, are infection, stroke, intracranial hemorrhage, and status epilepticus. So through your frequent neurochecks you're going to be on top of that, and you'll obviously be identifying that. The proper care of the patient will ensue. CT of brain, treat the status, whatever needs to be done. So in conclusion, I would just like to say we at the Minnesota Epilepsy Group are very excited about all these new surgical options for our patients. More of our patients with intractable epilepsy are getting more options, and the invasive EEG options, including this SEEG, are really expanding what the options are. So thank you for listening to our video. If people could take the time to give some feedback as to whether this information is useful, that would be very helpful.